Respected dignitaries of Indian Arthroscopy Society Nagpur, and Arthroscopy Society of Nepal. Regards from myself, I am Dr. Vivek Basugal. I work in AKB Center for Arthroscopy, Sports Injuries and Regenerative Medicine inside BNB Hospital in Nepal. And today I'll be talking about radiology and decision making in cough injuries. Before starting my talk, regards again to Indian Arthro Society and Arthroscopy Society from Nagpur, from myself and from my society. So I also bring lots of greetings from my country. So shoulder pain is very tricky situation, as has already been discussed. Shoulder pain is that many of these pain generating structures are overlapping. So it is shoulder pain. To diagnose a pain in around shoulder is very enigmatic and sometimes very tricky. There are many intrinsic shoulder conditions that can lead to shoulder pain, like shown in this picture. And today we'll be discussing about the rotator cuff here. We must not forget that there are many visceral conditions which has their referred pain around shoulder. So before jumping into the conclusion, we have to rule out all these visceral causes that may be possible cause of that shoulder pain. So this was a study from Byam et al, and he did pain mapping for common shoulder disorder, and this was the picture of his pain mapping. And what we can conclude is in many of these intrinsic shoulder conditions, the pain mapping overlaps. So it makes it even more difficult in this shoulder condition to make a diagnosis. So to make a diagnosis, what we need is we need a good history, we need good examination, which has already been covered, and there is some need of some injection test and need of good investigation. Then only we can diagnose what actually is causing this shoulder pain. So I have made an animation to tell about the biomechanics of the shoulders and how this investigation works. So this is a shoulder joint, and shoulder joint is covered by the rotator cuff muscles, supraspinatus from up, subscapularis from front, and in external rotators from the back. When supraspinatus, so this is long head of biceps and this is bursa. When supraspinatus contracts in single, what it causes is it initiates the abduction of that shoulder joint. But when these rotator cuff act together, what happens is these all force vector centers toward the center of the glenoid. So it gives a stable fulcrum over which the deltoid can act and thus lead to smooth and good abduction of that shoulder joint. So when this rotator cuff is turned like this in supraspinatus tear, whenever the rotator cuff are contracted, only the supraspinatus is not contracted, and what happens is now the deltoid acts, but it not only abducts, is it also moves the shoulder upwards. And what it will lead to is it will lead to the upper part of the humeral head and lower part of acromion being eroded one another and lead to various arthropathy. So this is another animation which shows that uh, as the acromion size of the acromion increases, the supraspinatus or various muscle is squeezed more in longer acromion, so it leads to more chance of rotator cuff injury and impingement. So this all biomechanics becomes the basis of these investigations, mainly the plain X-ray. So in shoulder joint, while evaluating, the plain X-ray is very, very important, and the plain X-ray most important view, I must say, is the true AP view, in which the anterior and posterior rim of glenoid overlaps. And most important, one of the most important one is the acromiohumeral distance, which is calculated by drawing two tangent line, one from below the acromion and another from above the acrohumeral head, and distance between this is the acromiohumeral distance. And if this is less than 6 millimeter, that means there is rotator cuff tear, or maybe this may be irreparable one. So another is acromial index. It is calculated by drawing a line that joins the upper and lower point of the glenoid, and tangent line is drawn from lateral edge of the humeral head and lateral edge of the acromion. Perpendicular are dropped down, and acromial index is the ratio of glenoacromial distance to glenohumeral distance. As the glenoacromial distance increases because of longer acromion, the acromial index increases, thus the chance of rotator cuff injury increases. So another is critical shoulder angle. in which the same line that joins the superior and inferior point of the glenoid is drawn, and from inferior point, the line is drawn towards the lateral edge of the acromion. The angle thus subtended is called critical shoulder angle, and if it is more than 35 degree, it is also a risk factor for rotator cuff injury. So CSA also increases when there is lateral overhang of the acromion. So indirectly, the lateral overhang, it is the length of acromion that is more important for the more important risk factor for the rotator cuff injury. Another important thing is the type of acromion. We need a good outlet view, that is scapular Y view, to see the type of the acromion. The type may be flat, it may be curved, or it may be hooked. And according to Biglani et al., the hooked acromion is the risk factor for the rotator cuff injury. Another important thing which we have to see in plain X-ray is the presence or absence of the rotator cuff arthropathy. What happens, as I have already shown in my animation, when there is supraspinatus or superior cuff tear, the head not only rotates, it goes upwards as well, and there will be friction between two bony surface, the inferior acromion and uh, superior humeral head, thus leading to sclerosis. And this is called the acetabolization of the acromion, and it is seen in X-ray as the Sorcil sign. And Hamada has classification this arthropathy into various grading, and maybe from grade 2 onwards, they are not amenable for rotator cuff repair. Ultrasound, uh, as already been discussed, is very important investigation in rotator cuff assessment of shoulder pain. This is non-invasive, radiation-free. They are relatively cheaper, and this is very dynamic thing. We can move the joint and see the excursion of the tendons, and we can always compare whenever we have confusion to the other normal side. So problem in our setting is the skilled manpower, skilled musculoskeletal ultrasonologist is very rare. Their utility in case of partial tear is still questionable. This is very difficult in obese patient, and there is condition called anisotrophy, which may lead to false positive or false negative diagnosis of rotator cuff injury. So it has been norm in our practice in our center that we always uh, patient always go through the ultrasound examination. In every shoulder condition, we see four distinct layers: the skin and subcutaneous tissue, then deltoid, then rotator cuff tendons, and then the humeral head. So these are the four distinct structures which is seen in the USG. And in ultrasound, the long head of biceps tendon can be seen, whether it is subluxated, dislocated, whether it's in position or not. And then another thing which I have already mentioned is it is very dynamic, and we can see whether the cuff is continuous or not, and it is moving along with our motion of the limb. So this is very advantageous, and it is a systemic analysis published in VJSM, and according to them, USG is even superior to MRI or MRA. But I must say this cannot be generalized in our setting because of obvious reasons. So for us, magnetic resonance imaging is the investigation of choice till date, and magnetic resonance imaging can differentiate between partial thickness tear and full thickness tear. Partial tears can be classified into articular, bursal, or intratendinous. This can be again classified according to the size. Grade 1 is less than 25%, grade 2 is 25 to 50%, and grade 3 it's more than 50%. So to evaluate the full thickness tears, we have to evaluate size, shape, number of tendon involved, muscle bulk, fatty infiltration, and retraction. So this is the MRI film which shows that this is the axial section. We have to see all of this section. We have to see anterior cuff, posterior cuff. We can see pristine subscapularis and posterior cuff in this axial cord. Also, we can see the long head of biceps in its position, and it is not subluxated. We have to see the coronal cord in which long head of biceps is seen first, then other cuff tendons. The superior cuff, that is supraspinatus, is pristine except for some changes over the articular side. And uh, again, we have to see the sagittal cut, where the we have to evaluate the atrophy or fatty infiltration of the muscle. So this is the pathological one. where we can see the superior migration of the humeral head, the calf tendons have been torn and it has been retracted. The axial cord shows good amount of supraspinatus tear which have extended up to the subscapularis. Then the cystic structure, the arthropathy, the humeral rotator cuff arthropathy is also seen, so as also the posterior instability is seen, and the status of rotator cuff muscles is also seen, in which we can see good fatty infiltration, maybe it is Cotillier type 3. So after evaluation, what we have to do is we have to characterize the tear in respect to size and shape of the tear. This is very famous paper from Burkhardt and Davidson. According to them, length is calculated in coronal film and width is calculated in sagittal film. And by them, less than 2 centimeter is good to repair. And we have to classify according to tier. Batman or Kofel can be used, small, medium, large, and massive. And accordingly for shape, Burkhardt or Ellman classification can be used. Tendon retraction is very important finding we have to see in MRI. Patty has classification according to stage 1, 2, or 3. Stage 1 is retraction up to the footprint. Stage 2 means retraction up to humeral head. Stage 3 means retraction up to the glenoid. So Gottelier fatty infiltration is very indispensable for decision making. And stage 3, stage 4, where fat is as good as muscle or fat is more than muscle, is are signs of bad tear. Also, the muscle atrophy can be assessed with the tangent sign, where superior point of the scapula and superior point of scapular spine, the tangent is drawn. And if the muscle bulk is below this tangent line, this is the poor prognostic indicator, and this usually correlates with the Gottelier type 3 and type 4. So besides all these, the bulk of muscles in coronal section is also to be seen, because in acute tear there may be retraction, grade 2 or grade 3 retraction, still the bulk of muscles may be very good. So this is not a bad indicator. If you can see good muscle bulk, that is a good indicator that it may be repairable. Other information that can be seen in MRI are the types of acromion, the AC joint arthritis, or even the signs of instability. So this is only for completion. CT and CT arthrography has little role because of advent in MRI. Though MRI can be, the CT can be done where the MRI is contraindicated if the patient is claustrophobic, where metal implants are used, in which MRI is contraindicated, excessive movement of patient is there, and where associated bony lesions are there, because bony lesions are well seen in CT. So after seeing MRI, CT, X-ray, or USG, we have to make a decision regarding the treatment. Before making decision, we have to know the natural history of the cough. As many studies have shown, even asymptomatic patients will have cough tear, and this cough tear increases with increasing age. And among the asymptomatic patient, almost 30% of partial tear and almost 50% of complete tear becomes symptomatic by 2 to 3 years, and 50% of full thickness tear and almost about 30% of partial tear increase in size in 2 to 3 years. And symptomatic large painful tears in old age are the tears which are bad regarding the prognosis. So partial tear, conservative management, debridement only, and cough repair are the three treatment options. The conservative is always first choice. Debridement is done for grade 1 and grade 2 tear, and though they may be better clinically, disease progression is not stopped by debridement alone. Cough repair is done for grade 3 tear, that is more than 50% tear is involved. When if in bursal side less than 50% of cough tear may be subject to cough repair. uh, Patients who are symptomatic with functional deficit, with large tear, and who are active and acute lesions may be subjected for cough repair in first go. Cough repair may be transtendon repair or tear completion and repair. Many discussion and many controversies surround between these two, but nowadays many surgeons advocate for tear completion and repair. In full thickness tear, conservative treatment is first treatment that we have to advise. And um, in patient with good comorbidity, stiffness, and old age, and with scapular dyskinesia, and patient who are smoker, drinker, and very obese, these patients are the candidate for conservative management. But as we have already shown, the full thickness cuff tear are very much prone to progression, and repairable tear may become irreparable. So whenever possible, if cuff tear are found to be repairable, they have to undergo surgery for repair. And the criteria for irreparability, we must know there are some clinical criteria like pseudoparalysis and lag signs. Radiological criteria are Pate type 3, Gottlieb 3 or more, positive tangent sign, acrohumeral distance less than 6 with arthropathy in X-ray, and if involvement of posterior inferior tendons like teres minor, and if in case of very last year, these are sign of irreparability, and in these cases, the treatment is differed. So I have made an algorithm. Uh, the MRI confirmed cuff tear may be acute traumatic tear, and in acute traumatic tear, what we do is we usually do early operative reconstruction. In chronic tear, this may be small size with Pate 1, asymptomatic, very old age and comorbidity. In these cases, the first line is conservative always. If there is improvement, we have to follow them with early MRI. If persistent pain or if deterioration, then surgery is advised. In case of medium size, Pate 1 and 2, early surgery is advised. And if in case of massive tear, irreparable tear, first to advise is conservative. If not improved, then treatment options like partial tear, margin convergence, SCR and RSA, and even tendon transfer has to be advised. So take a message, MRI is still investigation of choice in our practice. X-ray shows the indirect signs. Ultrasound investigation cannot be generalized. The findings can be generalized in our setting. Many tears are asymptomatic, but they do progress with time. So we have to be very careful to deal with them. Symptomatics are the one which usually progress rapidly, more so in oldest patient. So having said all this, MRI and history and clinical examinations are the main thing that decides our that are important for decision making than these MRI and all. Thank you so much. Thank you for patient learning.